We're going to go ahead and start this particular breakout session. My name is John Evans. I'm CEO at VITL. I just wanted to be able to introduce probably a man who needs no introduction, but I'll do that anyway. Mr. Al Gobeille. Al is chair of the Vermont Care Board here in Vermont. He also heads up Gobeille Hospitality, which has a number of restaurants. I think many of us here in Vermont are familiar with Shanties on the Shore and Breakwaters. Al is a graduate of Norwich University and also a fellow former Army officer. Hoorah! So I'd like to turn it over to Al, and you don't have any slides. You are just going to speak. So it's all yours.
So the all-payer model. How many people here have been to any meeting where it's been discussed? Okay, well, according to the paper, we haven't talked about it. So you're the secret cabal that knows something about the unicorn called the all-payer model. What we know, and all the folks in this room know, is that what we have in the healthcare system today is fragmented and isn't working for most of us. The reason that you're all here today, I hope, is to learn new skills, new things to improve on that. I think something we also know is that the way we pay for healthcare has a tremendous impact on the way that it's delivered. And so, how are you, sir? So what the all-payer model does is it changes in a material way the way we pay for healthcare. And that's what we've been talking about. And Richard, how long have we been talking about this?
I've been talking about 33 years.
33 years. So I got on the Green Mountain Care Board about 5 years ago, and we began talking about it right away. We created an all-payer model in the state. How many of you are aware of it? It's a shared savings model. It involves Medicare, Medicaid, and commercial. We did it in the dark of night. We never told anyone. We snuck it in, and we have the bulk of the providers in the state participating in it. That I have described as training wheels, because shared savings, as most of you know, does not fundamentally change the incentives that would help lead to an unfragmented or defragged delivery system. So we've been doing that for years to try to get ready for something bigger, better, faster, stronger. And a little over 2.5 years ago, Anya Rader-Wallach and I held a meeting at the City Center in Montpelier to announce that we were going to pursue an all-payer model. We then, in the last 2 years, have been working with providers, with hospital leadership, with federally qualified health center leadership to try to figure out what an all-payer model agreement could look like. During those 2 years, we met probably 100 times with members of the legislature and members of the public and members of the provider community. It's funny that Richard's here because Richard chaired a meeting that met every Monday morning for 4 hours with providers to try to figure out what the provider framework would be within an all-payer model. The result of that is what we call the framework document, and also some good thinking on how we could pay primary care and other providers in a model like this. And so, in January, we released a term sheet. It's called a term sheet because in a contract there's typically terms and conditions. So we released this term sheet. A week ago, we released the final preliminary draft, might be, could be. I can't remember all the qualifying words that CMS made us put in front of the word agreement, but basically it was like, maybe someday agreement. And what you can see from it is that there's fundamental changes from January till last week. And those fundamental changes were driven by stakeholder input. And so we're kind of proud to get to the moment where we can transparently show the document and get public feedback on it. And that's where we are now. And so I want to talk about it a little bit. And then, frankly, I want to take questions because I think questions are way better than having me just talk. So the all-payer model agreement, most people thought was going to be a Medicare waiver. How many people thought that? Well, I just talked to a lawyer in the hallway, and she's like, but there's no waivers in it. Well, that was the trick. Okay? It's really an agreement to allow Medicare to participate in a model where we move from payers paying fee-for-service to payers paying a per member per month. So the all-payer part is an opportunity for all payers to pay in a fundamentally different way and make some of the rules that they have go away to allow it to be easier to deliver care to Vermonters. That's the high-level thinking behind it. In order to get Medicare to agree to that, you have to promise Medicare some things because CMS doesn't give up the keys to their car very easily. So the things we had to agree to are that healthcare spending in our state for what we think of as A and B services will not grow faster than 3.5%. It's a target. It's not binding financially. We don't even have to apologize until it gets to 4.3%. But we had to make an agreement with them for the totality of growth in our state. And we also had to agree to measure some population health level things in order to allay their fears and allay our fears that changing the way we pay for health care might in any way be bad. Those high-level population health measures are, we're going to measure the access to care with a primary focus on primary care. We're going to measure our ability to treat chronic conditions. And there's a bunch of measures that do that. We're going to measure whether or not we can improve on our suicide rates as a state as compared to national benchmarks. And last, we're going to measure the amount of opioid overdoses as compared to national benchmarks in the state. And if any of you are aware of the Maryland Agreement, the only other one like this in the United States, they focused primarily on measures that you would think of in acute care, like readmissions. And to the credit of the doctors and nurses and other providers in our state, CMS is not concerned about those measures with us because we're a high-quality state. So we thought about measures that would actually get at what we think we're weak at. Now, that's kind of crazy to do as a bureaucrat because bureaucrats want to look good, right? So we want measures that are easy to attain so we can declare victory and never admit that we have weaknesses. But that's not the type of person I am, and that's not the type of people we had working on this. We honestly believe we have a problem with primary care access in the state of Vermont. If somebody disagrees with me, I'm not always right, but I believe we do. I believe we don't make the right investments in mental health in the state, and we should measure our ability to improve our investments and our results. I believe we have a problem with opioid treatment in our state, and we should hit that head on, and we should be accountable for it. And last, the whole idea behind the all-payer model and the whole idea behind changing payment is that if 86 cents on every dollar goes to treat chronic conditions in the United States, then we should measure whether or not we can improve that with this model. And so those are the big things we had to promise CMS. Okay? In addition, we had to promise them that we would save the Medicare Trust Fund money. Now, those of you who get paid by the healthcare system, if I say we're going to save money, you may immediately think, oh, great, that means we get less. But if you look at the actual model agreement, we get more before we get less, which means less is more. That is government math. So, and we can argue over the math, and I will tell you that Paul Harrington's here, and he has been very vocal in trying to understand the math and make sure that what I just said is actually a true statement. But basically, in the agreement, we continue funding for the Blueprint from Medicare, SASH from Medicare, and community health teams from Medicare, and we get some other money, which totals over the life of the agreement, which is a 6-year agreement. This is where, again, government math. It's actually a 5-year agreement, but it lasts 6 years. Everybody cool with that? Okay. Year 2017 is year 0. So the only reason it's year 0 is so we can get $9.5 million. So is everyone cool with it being year 0? See the thinking there? It's logical. So the point is that we have some upfront money that we get that was going away. And so then we have to save Medicare money. And my belief is that we can do that under this model and actually improve quality. And so that's what we had to say we would do with Medicare. There's other things, but I don't want to stick on it too much or bore you too much. So that's what we had to do. Now, what's the opportunity? So anyone here who knows me knows that I'm a big government, top-down. I think that 5-year planning by the Kremlin is the way to... Why aren't you guys laughing? I mean, so this opportunity is not the government taking over health care. This is the government saying, we have an agreement that allows providers to have an opportunity. Okay? An opportunity. They do not have to take the opportunity. There's nothing in here other than the total cost of care measure and the large measures that they are unwillingly signed up for. Okay? And again, those are non-binding. They would be embarrassing if we couldn't improve access to primary care, but they're not binding in the sense that we're forcing providers to move into some government-controlled system. The point is, we're allowing there to be an opportunity for providers to come together and be paid differently. And there's a couple of opportunities. Okay? The first opportunity providers have is to stay in fee-for-service. It says it in the contract. Okay? So if you like what you have now, you can stay in it. But here's the problem with Medicare. It won't stay the same. MACRA and MIPS is coming. Okay? The rule will come out soon. And it will change fee-for-service in Medicare in the United States. So providers can choose fee-for-service, but we, the state, can in no way insulate them from the MACRA MIPS challenge that they will face. I want to be clear about that. The second thing is providers in the state can participate in shared savings. When I say providers, I'm talking primary care providers, because those are the folks that come together to form these organizations. Can be done through the leadership of hospitals, leadership of federally qualified health centers, leadership of independent practices, but basically it's primary care coming together. So they can come together for shared savings. And if you read the contract, it says something about 30% risk. Has anyone read it, by the way, other than Paul Harrington? Yeah, it says something about 30% risk. That is a complicated way that CMS talks about basically stop-loss limiters and all this different stuff. It's basically track 1 in shared savings. And so providers can participate in that and be in the model. Last, providers can participate in what we call full risk. And again, because this is literally, could be a contract with Medicare, the question becomes, is it actually full risk? Meaning, if I'm over by $1,000, do I lose $1,000? And the answer is, that's actually not the way NextGen works. And you can move towards that over time. And the question for the providers is, in our state is, how much risk do you really want to take? And how do you want to work your contract out? And so that's sort of the risks structure. Stay in fee-for-service, shared savings, or more of a capitated-esque payment. And so that's where this is all headed. So people have asked me questions like, what if I'm a senior and I want to get care in Florida under this model? Am I prohibited from that? And the answer is, you are not prohibited, because nothing in this agreement can take away one single benefit you have as a Medicare beneficiary. And Medicare does not allow networks in Medicare traditional fee-for-service, and therefore would not in this. And so that is simply not something that is possible. And so that's a very clear, straightforward answer. The other questions that folks have is, what happens if no providers sign up? And I've answered it with this way of thinking about it. I was taught when you negotiate something with somebody to always watch their feet. Have anyone ever heard this? If you haven't heard this and you don't negotiate stuff, you might want to listen to this, because it's actually really helpful. Never listen to what anyone ever says. Watch their feet. They will tell you they're going to leave, tell you they're not going to sign it, tell you they don't want to sell the property, tell you whatever they want. But if their feet are still in the room, you still got a chance. Okay? With providers, if you're, and Digger quoted me and people ran with that and acted like I meant feet leaving the state. What I mean is free will. Providers can say, I want to do this or I don't, and they're going to do it with their feet. Listening to everybody talk about it won't matter. We'll need to wait to see if people actually sign up for it. And so I'm going to be in a really weird spot if we have a new governor, a new lieutenant governor, a new speaker, a new head of the Senate, and we came up with this idea that nobody signs up for. That's going to be a very interesting time. Right, exactly. And so that's sort of what's going on with the all-payer model. I will also say that there's a lot to do with Medicaid, but the two agreements are not tied together. You could sign a Medicaid agreement and never do the all-payer model agreement. They don't have to be together, but I pushed the administration really hard to keep them together where they needed to be together. Because how many people here think Medicaid is perfect and doesn't need to change? Okay, so the Medicaid waiver had to be able to be changed if you do an all-payer model. And so in its core, it had to have wording that allowed that, because the old waiver didn't, and it didn't have any resources. So there's resources in the Medicaid waiver now to help build what could be an all-payer model. They go away, by the way, if we don't sign an all-payer model agreement, but the Medicaid waiver doesn't go away. Okay? So that's sort of the whole thing, big picture thing. But today isn't about OneCare or this whole conversation with the Green Mountain Care Board. Today's about VITL. And so I just want to end with this thought for you. I went to the VITL board meeting. Was it your annual meeting? Yes. What was that? Annual meeting? And retreat. We don't retreat. I went. Sir, what?
It was an active step forward.
It was a, thank you. It was an attack in the reverse. So we talked about this at the VITL board meeting. And here was what I challenged John to do, and the VITL board. We have a thing called V-Cures. How many of you have heard of it? It's really cool. We have VITL. We have other technology at OneCare. We have other technology at AHS, other technology at DIVA. We've met with IBM to say, how could this all work together? There's other players than IBM. But the question for VITL that I left them with is this. If we're truly going to change the way we pay and take a quantum leap forward in the way we integrate the system across the care continuum, don't we need to do it with data? Because why I have V-Cures, I can never answer. I admit it, I don't know anything really about IT. I just don't. I can do chowder. But I'm not an IT person. It sits at the board. It's a great resource, but we could use it as a resource without having pride of ownership. So the question is, where should these things live? The state HIT plan was created, came before the board, and we never voted on it. Because I don't feel that it was visionary enough or really looking forward enough at where we're going. And so the question that I have for John is, and the challenge I have for him is, what are we going to do? How do these things come together so that we can have a data utility that can tell us how we're doing with things? Specifically, is there a better way to do measures so we don't have to bother clinicians all the time? Wouldn't that be an advancement we could all support? Yeah. And so that's what I left them with last week, and that's what I'm still challenging them with. And I challenge all of you in the room to think about it, because I will not solve it. I know that. But we have to solve that together if we want to do this. I would argue we have to do it even if we don't do an all-payer model. We have to figure out a better way to do HIT at the state level. And when I say the state level, the HIT plan sort of tries to be that 5-year planning document that I told you I enjoy so much. It can't be, because we don't know everything that the private sector is doing. But we shouldn't create things that are in the way of the private sector or just not informed by the private sector. And so that's where that's at. So now I'm going to stop, if that's okay, and we'll do questions. And Richard, you're not allowed to ask anything. Yes, sir. And if you could just say who you are, who you represent, and...
I'm Tom Pitts. I'm from Northern Counties Healthcare. We're at QAC. Just a quick question. Why do they call it all-payer?
Yeah, so...
It's just Medicare.
Well, it's interesting. So first of all, an apology. We are the worst at branding anything. I mean, we should have used like Nike, you know? I mean, it's all payer because if you think about it, if you want to do something with Medicaid and commercial, and you go to the hospital association and say, hey, I have a great idea, we want to do something with Medicaid and commercial, and you don't have Medicare, it's a foot in two canoes, and you got two paddles, as Tom Huebner describes. So we call it an all-payer because the federal government won't give you the keys to the Medicare car if you don't agree to make whatever you're doing with their car the same across all payers. So that's why it's called all-payer. But the all-payer agreement, all-payer model, it's all bad names because it's not all payers, it's not all providers, and it's not all patients. So it sounds like it's this big, giant takeover thing. It's not. Our initial year 0, our total amount of lives in the model is 0. You know, so year 1 is more aggressive, and then by the end, we hope to have 80% of Vermonters in the model. But it's just a directional goal. We have no ability to force that. So, yes, sir.
So, since the FQHCs have a separate agreement with the person,
Yeah.
how do they play in this or don't they play in this?
It's a great question. So one thing we were very careful to do is not harm any of the agreements that hospitals or FQHCs had. So for example, critical access hospital status, sole community provider, Medicare dependent hospital, or the FQHCs in the way that they're funded. So we took that off the table. Okay, so your funding doesn't change. But if you decide to sign up, basically your attributed lives go with you, just like you do now with CHAC, and they go with you, and then you become part of an integrated system. And so the question then becomes, you may still be paid the exact same way, but the integrated system is at risk for the total cost of care associated with your patients. But you don't have to be at risk. So you may be a willing participant for integration, but not necessarily at risk financially, and not really have much change in the way you're paid because of the status that you have. So, I mean, there's a lot, we tried to make this as workable as possible to not lose some of the advantages we had. Did somebody say there was a question over here? No? Go ahead. You got to say who you are and who you represent. Yep.
From Northwestern Medical Center.
Okay.
Following up on that question, FQHCs are paid on a cost basis. They submit all their costs every year. They divide that by the number of encounters, and it come up with a per encounter cost. And they are paid at about double the rate that
Yeah, so is Todd Moore, I thought I saw him back over there. So I wouldn't. I would try to pay everybody the same. But here's where the agreement kind of ends, okay? We get the keys to the Medicare car, okay? We get permission to do something. ACOs have to make those decisions. And whether or not you attract providers is going to depend on, and primary care providers, is going to depend on how you answer those questions. So, you know, I don't have an answer, nor should I have an answer.
Hi, Steve Cummings from Brattleboro Memorial Hospital, and I think building on that question, I had kind of the same question, but also, can you talk a little more about the, I've seen some slides related to this, and there was a really big number of $200 million or something, and overall dollars that are going towards this, and can you talk a little more about the investment in primary care in particular? You know, I'm sure you know we've got primary care practices, and we're trying to meet the Brattleboro area demand for primary care, and we can't meet it. We've got full panels and patients still trying to get in, and I'm curious how this might help us to expand and meet the need. Yeah,
so what you're talking about is there was a spreadsheet that was shown to the board in one of our public meetings that, trying to remember some, you know, see it in my mind's eye, it's a $209 million number in the right-hand lower column, and in that spreadsheet is an opportunity for spending if we do an all-payer model agreement, and it's basically 4 delivery system reforms. And in that is money for a whole host of things that are pretty indiscriminately labeled so that we didn't tie our hands with the federal government. So it doesn't say money for primary care nurse practitioners in Shelburne. It says improvements to community health and yada, yada, yada. And so how we choose to use those resources, how the private sector works with us to try to use those resources, again, those are questions that shouldn't be answered by us because I don't know your needs and I can't measure those across the whole state in real time. But you know, the point is that if we don't figure out a way to pay primary care better, pay primary care differently, pay primary care in a way that doesn't drive them crazy, then this model will fail, but so will our entire healthcare system. And so that has to be, you won't build a transformative model without that. And you won't attract primary care. So that has to be the crux of it. And there's money and opportunity to do that. Because to increase primary care in terms of the denominator that is healthcare spending, by the end of the model, we estimate that Medicare, Medicaid, and commercial in a model, if it was, say, 80%, the spending will be $4 billion. Okay, that's a lot of money to try to figure out how to fix something that isn't a huge part of the numerator. So that needs to happen as part of this, or we're not building a better system, and we won't pass our measure. That's why we made that measure the way it is. So, other?
Nancy Brock from VITL. Al, who is going to administer that $4 million?
$4 billion?
Or whatever the subsets are. Is it the Vermont Care Board? Is it the legislature? Is it the private sector? Who decides?
Yeah.
How does that all work?
Yep, so how many people here have heard of Act 113? Okay, quite a few actually. Act 113 was passed last year, and it was a bill that was designed to sort of tell us, the negotiating team, because Act 54 told the Green Mountain Care Board and the governor to collaborate together and explore an all-payer model. And so Act 113 said, and that was 2 years ago, and last year they passed 113, and in it said, here's all the things that an all-payer model has to do. One of them is pay primary care better. Here's the thing it has to do. And then here's how it's going to be, how oversight will occur. And it specifically talks about the role of the Green Mountain Care Board in setting the budgets for ACOs. And so if there is one ACO in the state, or if there are more, we would set their budgets. But the money the $4 billion goes to the accountable care organization, and the governance structure of the accountable care organization has to answer those questions. I would think it would be very problematic if the legislature had any role in that. And actually, then I would, if I was the private sector, I would run away, because I don't know that that would be ever be what you would want it to be. Is that fair? Yep. Somebody else? Yes, sir.
Hi, Jeremy Derby from Ready Computing. We do a lot of work in healthcare IT. My question is about clarification on either the shared risk model, the fully shared risk or the partially shared risk. Will organizations have an opportunity to identify certain cohorts of their patients that risk applies to, or is that across the board for every one of the patients?
So each, Todd and Richard are better at this, each basically tin has to, you have to pick where you want to go. So a provider group would have to say, we want to join VCO, or if there's OneCare, or if there's CHAC, we want to join you with our attributed lives in this program. There wouldn't be the ability to say split. Yeah, because there's all sorts of other issues that could come from that. Yeah, absolutely. Yes, sir.
John Nason with Primary Health Partners. Are you looking at like an annual enrollment opportunity per year, or is it a 5 to 6 year commitment? And are there exit options through the term?
Yeah, so I'm going to try to not be confusing and be completely straightforward in my answer. If I confuse this, just stop me. The agreement for Medicare is 6 years, with the first year being year 0. The Medicaid agreement is a 5-year agreement that starts January 1st, 2017. So they don't really line up, okay? That's the agreement between the state and the federal government. Next, individual providers have the ability to sign up for one of these programs. You typically sign up for a year, and there's typically ways for you to get out of it, but that agreement would be between you and an accountable care organization. And so if they, for some reason, said they wanted a multi-year commitment but gave you something that you thought was a benefit for that, that could possibly happen. I wouldn't want to control that, but typically it has been a 1-year agreement. So, by the way, one last point. With the all-payer model agreement, there is a 180-day out where the state could get out of the agreement if we didn't like it. And that is throughout the entire agreement. So, was that straight enough? Yep. Yes?
I'm not sure how to work this. So with respect to specifically Dartmouth-Hitchcock, then how does that work, since they serve so many Vermonters? And yesterday, I think one of the panelists in this track alluded to Dartmouth having made a decision not to participate. And maybe you can debunk that.
Yeah, so I would never speak on behalf of Dartmouth-Hitchcock or any private entity, but my understanding is that they are not getting out of this. They got out of a different ACO program that they were a part of. I think everyone's read about Dartmouth-Hitchcock. I'm not going to opine or add anything to that. But I will say that remember that when primary care providers that are in Norwich, White River Junction, wherever, when they decide to come in with their Medicare dollars, stick with just Medicare, don't go to other payers, they decide to come in, those dollars are put at risk. Dartmouth doesn't sign off on the inpatient dollars on whether or not they can be put at risk. It doesn't work that way. So Dartmouth can be in as a part, but Dartmouth could be impacted even if they aren't a part. And so, again, people say a whole bunch of things. I watch people's feet. So I don't know what they're going to do. I hope they'll be in. They've been a great partner at all the meetings we've had. I would hope it would continue. So, yes?
Matt Habedank, Northwestern Counseling and Support Services. What impact would the all-payer model have on the designated agency system or mental health service providers?
Yeah, so I hope it'll have a really positive one. There's money in the Medicaid agreement to raise the rates for the DAs and to hopefully, there's no way we're going to measure opioid and suicide and then like not make investments there and think that those measures are suddenly going to take care of themselves. And so there's money that is in the plan to do that. But the question I would have back to the designated agencies is, how are you going to integrate? How are we going to defrag this thing? I mean, we've tried paying everybody more, okay? And I will tell you that all the times that I've had to sit running a board meeting and hear from Vermonters that are angry with me personally about health insurance premiums is not something that I forget or that doesn't scar me in a way. And I don't mean in a negative way. I hear their voices. They aren't grandstanding. They're real people. And so everyone in this room needs to understand that if everyone just thinks they need more, what am I supposed to say to those folks? Just suck it up? And if you had to face them, what would you say? That you don't get it? You're not, you shouldn't have an individual plan. You should have worked for IBM. I mean, what do you say? And so the challenge I have for the DAs is there may be more money for you, but how are we going to fix this? And I'm not picking on the DAs. I mean, I'll pick on everybody equally. It's great to be the chair. Sure. Like, let me give you an example using the DAs, okay? So, a year ago, I was asked to go to a meeting by Mayor Murrow Weinberger, by the governor, and by TJ Donovan. All three simultaneously. I'm like, what are they up to? I got all these voicemails. So I went, and it was a conversation about the wait list at the methadone clinic. And so I went, and I sat in the mayor's office with the governor, TJ, the mayor, John Brumstead, Bob Bick, Eileen Whalen, Jason Williams, and a few other folks I can't remember. And I listened, and I looked at my watch, and I listened for 32 minutes. Okay? 32 minutes of political speeches, political posturing, and reasons why we can't do anything. And then I turned to John Brumstead and I said, John, could you tell me, or Bob, because I'm just a restaurant owner, gang, I really don't know anything, okay? But if I had a wait that I couldn't deal with at my restaurant, I'd be thinking, how many more square feet? How many more ovens? How much of a bigger hood? How many more friolators? How many more wait staff? Do I need new POS terminals? What about my HVAC? We'd figure it out. So I sat there and I said exactly that to John, who I have unlimited respect for after 5 years of dealing with him. He turned the color of your tie, and no one can see it, so think of a Heinz ketchup bottle. Okay? And he turned to Bob Bick and he said, Bob, if you'll work with me for 3 weeks, I bet we could come back and tell these guys a plan. And Bob Bick said, okay, and Bob Bick put his head down. And I didn't understand the body language. There was another 28 minutes of political speeches and posturing and everything, and we left. Okay? And as I left, John Brumstead walked up behind me and said, he's not even going to answer my call. And I said, just trust, trust, trust. I went outside. Bob Bick said, hey, Al, you got a sec? I said, sure. He said, he's not going to call me. And I said, he's going to call you. We're going to do this. We're going to fix this. We're going to fix this. So when I say fix it, that's what I mean. And so here's what happened. I run 5 days a week, and I typically run on the tie path in Shelburne. One Saturday I was running. Anyone here know Kieran Donnelly? He's a realtor. He knows so much about healthcare now. So we're running, and we run into Bob Bick. Bob Bick walks on the tie path with his dogs every Saturday morning. Run into him, and I say, how we doing? He's like, he called me. I said, okay. Did you talk to him? He said, I did. I said, well, that's great. What are we doing? He said, we're coming up with a plan. I said, fantastic. So I kept running. I come running back. It's like, you know, it was 2 miles, so it took me like an hour. And so we come back. Guess who we run into on the other end of the tie path? Dr. John Brumstead. So I stop and I say, hey, John. No, it kind of went like this. I said, hey, John, how we doing? He said, oh, man, I had a great conversation with Bob Bick. I think we got something. That was like November 2nd last year. By January, we had 25 primary care docs prescribing Suboxone. Right now, there's 48. Nothing's perfect yet. Please don't take it as mission accomplished. I would never do that. We don't do that. But that's neither person in our current payment system had any reason to talk to the other person about this problem. Brumstead had his smart folks go to the methadone clinic and do whatever it is that smart folks do, lean or fat or whatever it is that you do with management. What is that stuff? Trim. So Six Sigma, whatever. They did that haiku thing. And they literally helped the methadone clinic become more efficient, both of operation and of finances. And so that's like a partnership thing. Well, the fee-for-service world doesn't make that happen. It doesn't make it happen at all. It takes leadership. Okay? It'd be great if the payment system actually helped that happen. Okay? It takes commitment. It takes recognizing a problem. Okay? And by the way, they get all the credit. They did all the hard work. And so it's actually had an impact on the wait times and how we're treating, you know, basically heroin in our community. That's a good thing. But it shouldn't take a mayor, a DA, a board chair, and a governor. That stuff should happen because it's in the best interest of our patients. And the way we pay for health care should not reward not taking someone's phone call. Because here's another point. John Brumstead came before the board and said, in 2015, because of dirty needles, they did 34 valve replacement operations on folks at a tune of $500,000 because they were infected. All because they were addicted, all because they were using dirty needles. And so it isn't just a matter of how long's the wait list, it's what does that wait list do to our healthcare costs. That comes out of the Medicaid budget, folks. And so this stuff, as you all know, better than I will ever know, is interconnected. But so that's what I mean when I say we need to fix this. Yep.
Is after we go through transition for 5 or 6 years, is there a vision for what the new business model looks like at the other end? Because I'm thinking it's, you don't know where you're going, it's really hard to get there. So in terms of trying to design the fix, I'm just curious if there is a single vision or we're going to figure it out once we get there.
Yeah, so, you know, questions like that are really dangerous because people want to be able to answer them, you know? And I've tried to be really disciplined in this, and I want to give you my answer. It's very genuine, okay? If you want me to have the vision, A, what do we need all of you for? But B, the government can't do that for you. Meaning, I think that when you change incentives and you get smart people together that are no longer tied down to 15-minute office visits or the fragmented nature of our current payment methodology, you will be able to work on how this stuff can be done differently. And that vision should come from you, and it should be community-based and not statewide based. It should be local, okay? And then it can be fantastic. If it was ever going to be decided by a 5-member board, you should all get rid of me. I mean, I think that you have to come together, you the providers, you the folks that work in healthcare, and work on how this can be. But we know, and when I say that, I don't want to cop out of the easy things we can say, which is we think we need to do some incredible things to primary care that I've already talked about. So that's part of the vision. So 5 years from now, okay, Should we be still arguing over fair and equitable pay for primary care? Then we haven't accomplished our vision. If we're still only having 6 minutes to see a patient out of the 15 minutes that we record, did we accomplish our vision? Meaning, I don't think the vision should be this high castle on a hill. I think we know where we have to get to, but I just really don't want the state to answer it. I really want all of you to answer it. Is that?
So no, there's no vision. We have to create it, is what I'm taking from your answer.
Well, I think there is a vision. I do. I think that you're asking me to tell you what it is, and I'm putting it back on you. Yeah.
I'm asking, does anyone have that vision? I'm not asking it, does the Green Mountain Care Board, the government have it? I'm just asking, is there some kind of ideal or better
Yeah.
you're trying to get to? Because I hear lofty statements
Yeah.
like, we have to invest more in primary care. We have to improve access to care for our populations. But in terms of trying to figure out what's the game we're going to play, like right now, I provide a service, I send a bill to an insurance company, I get a discounted fee back.
Right.
That's the game we're playing right now.
Right.
If it has to be fundamentally different, is it that you don't submit claims anymore? Is it that you're getting paid based on the number of people you're looking at?
Right. So what I would say is that I talked earlier about there being a Monday morning meeting of providers from, all sorts of different provider types, and there being a framework document that was developed and a sort of a transition document that was developed. That, to me, would be the vision that you're talking about. And in there, it talks about, literally, in detail, about offering 2 different ways to pay for primary care. One being more of a panel payment, and the other being, I wouldn't want to get into the details of describing it, but fee-for-service with some, bells and whistles. But basically, opportunities that an ACO could do to fundamentally change what you're talking about, but with the detail that you're asking for. So that work was done for, I'm not even sure, was it 2 years or a year and a half, Richard?
About 2 years.
About 2 years. And so, the whole idea was, what is the vision for these things? And I can get you copies of those documents. What I don't want to act like is that I created them or they all came from the Green Mountain Care Board. That was provider leadership making them. And they literally have details about exactly what you were asking. But also remember that part of this may be, you still could be and could choose to be on fee-for-service. I think that's something that we all have to realize. There will be people who want to do that. And so the new way has to be articulated to you, and you have to buy into it or not. But that's where we're at. Other questions? How are we doing? Yes, sir.
We're an independent primary care physicians in the hospital-based ACO. I would definitely say we've had a positive experience, really based upon integrity and transparency. Certainly hoping to see that same thing transition to the VCO, which I understand is now the organization that will lead and administer this whole All-Payer.
Yep.
What is the role of the Green Mountain Board going to be in terms of what VCO is?
So Act 113 is very prescriptive in our role. I wouldn't try to quote it to you just from memory, but basically we would approve the budget for that ACO. Also, in the all-payer model agreement, in order to be an ACO, we would have to sign a letter with the ACO and send it to Medicare before you could become one. And so that means we have tremendous input on governance and other components of it. But I, like you, agree that the transparency and all of that has gone on, that has to continue because it can't be done any other way and actually make you want to be a part of it. So, we have a big role, but it's more oversight. It's not, hands-on. I think that I hate to just stick with it, but this has to be provider-led, provider-governed. It should not be kind of dictated by the board. Yeah. Yes, sir.
Charlie McLean, primary care. So the reason that Dartmouth chose to bail on some of the other shared saving programs was because relative to other parts of the country, we're probably doing a pretty efficient job here and in the Northeast in general. Looking forward to the 3.5% target, can we get to that? Do we have confidence that that is reasonable and really achievable?
Yeah, so it's, kind of like economists or weather forecasters. How do you project a trend and believe it? I think it's very hard to know anything next year. How do you know anything over 5 or 6 years? And so what I look at is does it pass the common sense test? And so yesterday we had our actuary come in with a model and talk about, on the all-payer target of 3.5, is that something mathematically that based on what we know today sounds reasonable? And what Steve Schramm said was, we estimate growth at 4.2% for A and B spending across payers and the like spending across payers. And we think with interventions done by an accountable care organization, we think it's reasonable that you'd be below the 4.3, because we're estimating 4.2, and that you, in fact, could be at the 3.5. And they gave a range of 3.4 to 3.6. But I just said that I don't know if I find it credible. But because there's no clawback or punitive thing from it, I think it's our best information at the time. And so I find comfort in the analysis, okay? The second part is the Medicare money, which is actually probably a bigger deal to me because it feels more finite because it's actually part of how the ACO would get paid, meaning the board will set the rate of growth on the money, on the base that the ACO gets. So right now, just as a raw number, we spend about $8,165 on Medicare beneficiaries in this state minus Part D, okay? Just a raw number. We would then trend that forward based on what we think Medicare will be. Now, the original agreement, the original term sheet, this is going to get weedy, and I'm sorry to do that right before lunch, but the original term sheet was a retrospective rate setting mechanism where we would look at what Medicare was last year, look at where it's going to be this year, and try to course correct to keep the ACO a little bit below national Medicare spending. We did some modeling on it. We realized that was flawed thinking. We, the state of Vermont, we did that work, not the state, not the federal government. We went back to them and said, this doesn't work for us, so we should either walk away or you've got to change. We then went to prospective rate setting, which allows us to use the Office of the Actuary's prospective national rate. So they can't hold us accountable if they're wrong. Okay, and I'm comforted by that mechanism because we then don't go back if we were over and take away money. And so that number is the number that's used for Medicare Advantage plans, and that's about 1/3 of all Medicare beneficiaries in the United States. And so if it was to underfund 1/3 of all Medicare beneficiaries in the United States, it would obviously be a bigger problem than just Vermont. And so I feel good about it, but it may mean at the end that we fail to save money. But remember what we're telling them, that we will either save money, improve quality, or both. So if all we do is improve quality, the demonstration is a success, even if we're over on Medicare spending. And I want to talk about Dartmouth really quick because I want to agree with you. And I even want to tell you what they said that I remember. Hate to make everything about running, but what they said was that it's a lot easier to shave a minute off your mile time if you're running 11-minute miles than it is to shave a minute off if you're running 5-minute miles. And they feel like they're a 5-minute miler competing against 11-minute milers. And their point is very, very valid, okay? And so that is something to consider, and just so everyone here understands, we're a lot of money below the national average and way below the high-end states. Maryland is like 11,800 versus our a little bit over 8,000. And the national average is like 9,800, 10,000-ish. It depends on what year you're looking at. That's why I say ish. But you may go back and look 2 years and say, well, it's less than that. But the point being, that we're over $1,000 below the national average, and we're way below Maryland. And so the question is, are we, our doctors and nurses and everybody have kind of been vegan triathletes. How many of you ever heard me say that? Yeah, and Maryland is kind of like chain smoking, meat eaters, So can we compete at that level with that Medicare Advantage rate? And so we did modeling, and it was shown to the board yesterday, in-depth 3-hour meeting, where we think that you can save off of trend the way we're talking with the interventions that the ACO is going to do. And so we think it's plausible.
So one follow-up, when you say Part D is out,
Yep.
it really means no risk on the whole pharmaceutical piece. Period.
That's right. Yeah, so for example, in a rate case that the board does, we might see medical inflation at 3.3% and pharmaceutical inflation at 10.6%. And then what we do is we put the two numbers together and we say growth is 4.3 or 4.4. If you ever hear that, it might be called medical trend, but it's medical trend including pharmaceutical. The true medical trend has to be adjusted down then. And so that's... Now, there's a lot of people who think Part D should be in because it would be something you could manage. But the problem is the federal government, because of the way Medicare Part D is done through insurance companies, doesn't have the data. And so we can't do it at this time. So, yes, sir.
Hi, Justin Stinnett, Central Vermont. So I was wondering if you could talk a little bit more about the example that you gave for a patient who was attributed, who joins the system, or their PCP joins the system, is attributed to Vermont, but then spends 5 months in Florida, which we know there's certainly different practice patterns down there, and how that'll affect your per patient per month payment, or if we would be responsible for the care that's provided while they're outside kind of our area.
Yeah, so basically I'm going to just talk about the way NextGen works sort of in generalities, because the first year of this agreement, 2018, is a NextGen-esque Medicare agreement. And the way that's done is the ACO would not be given the money for the total cost of care. There's a number like 65-35 where, and it can be done, it can be figured out like what percentage of care is done by providers that are not a part of the ACO. It might be home health, it might be Florida, et cetera. So that's withheld and the money's spent, but you are still held accountable for that spend. And so that's just the way that works. But it's not in it's not in money that would go to the ACO. And that can change over time and through agreements, but not the fact that you can get care in Florida, but the way the money flows.
We're going to have to build a big, beautiful wall.
John and I served in a little town in Germany where we got to go see a big, beautiful wall all the time. And I will tell you, I got to see the wall come down, and it made me cry. So, walls may not always be good things.
Right. Well, let's give a great round of applause.
Thank you, brother. I better give this back.